Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chi-Man-Chu, and I'm back with my friends, Sam and Sydney. Hey, guys.
Hello.
What's up?
We have Dr. Caleb Graham to talk about functional abdominal pain today. But first, Sam, do you want to remind us what this podcast is all about?
I would love to. So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Caleb Graham. Dr. Graham is a pediatric gastroenterologist and medical educator at Cincinnati Children's Hospital Medical Center. He has a clinical focus on disorders of the gut-brain interaction and motility. Additionally, he serves as one of the associate program directors for the pediatric residency program and is passionate about mentorship, coaching, and pediatric behavioral and mental health training in pediatric spaces. Dr. Graham teaches us about functional abdominal pain, the gut-brain axis, and a 3-bucket approach to treatment. Dr. Graham was previously consultant for Ironwood and AbbVie Pharmaceuticals. All efforts have been made to present balanced information about treatment options.
Hey, guys, I have a gut feeling that today's discussion is going to be great.
Oh, there we go.
Yep. Time to digest the main content, guys.
Oh, another GI joke.
Let's get to the belly of the matter.
All right, Chris, you're done.
All right. Hello, Dr. Graham. Thank you for coming on the show. First, because we're in a formal group, is it okay we go by your first name?
Absolutely.
All right. So it's Caleb, correct?
It's Caleb, yes.
All right. Excellent, Caleb. To help our audience get to know you a little better, could you, describe yourself to us? Give a little bit about your background and maybe something outside of medicine.
Absolutely. So I'm Caleb Graham. I'm currently a pediatric gastroenterologist at Cincinnati Children's Hospital. I'm also serve as a role as an associate program director of the pediatric residency program. So I get the fun job of seeing patients clinically and also teaching a lot of med students and also residents and fellows. I have a particular interest in disorders of gut-brain interaction, chronic abdominal pain, chronic nausea, as well as a big interest in mental health. A lot of my interest in mental health comes from initially I trained as a triple board resident, which is adult psych, child psych, and pediatrics. I decided to finish out my training in general pediatrics because I really fell in love with procedural medicine, and I found GI, and GI is the perfect blend of procedures, psychology, and cool pathology. When I'm not in the hospital taking care of patients or working with trainees, I do a lot of coaching. So folks at the Children's Hospital affectionately refer to me as Coach Graham. I do a lot of coaching of football, basketball, just kind of around the city for kids and for my kids. So that's kind of where I spend most of my time.
Can we call you Coach on the show?
You can always call me Coach Graham. Most people refer to me as Coach. You see random kids around the city. Kids around saying, "What's up, Coach? What's up, Coach?" So
I think I'm going to stick to that. Well,
I love that.
You Coach.
Yeah, I actually think we should do that if I remember as well. I mean, I'm probably going to call you Caleb, but I think at some point, Coach Graham, I got a question for you. All right, good. Yeah. In all sports, that's all sports too. It's do you do all 4 seasons?
I coach all the time. So basketball, football, those are the main 2 sports, and then do a lot of training of kids, things like that and stuff. So getting them ready for their sports. Yeah.
Nice.
Awesome. So I do, along the coaching mantra here, I do want to ask you a question here. We often ask about best advice on the show, and I feel like this is a good place to put it. What's the best advice you've ever received, learner, as a teacher, in your career, your coaching career? It could be literally anything.
Yeah, absolutely. I think probably the best advice that I got from when I was a fellow was one of my mentors at CHOP. He's a pediatric GI doc, motility doctor, and he told me the more you can do, the more you can do. It was really about versatility, right? So the more skills you pick up, the more skills you have in your toolkit, the more options you have available to you, the more things that you can go about doing. And so you never want to be in a situation where you find yourself kind of pigeonholed or having to do certain things. You want to make sure that you actually are, there's a lot of things you can do, and then you can kind of, set your own destiny in terms of what you want your career to look like. And so I thought that was great advice. And then also, fortunately, also translate onto in the sports world too.
Yeah, exactly.
Everyone likes a smart and versatile player, right? So the more positions you can play, it guarantees you're going to get some playing time. So, but in all seriousness, that was just great advice for me, and I try to always keep that, and just try to add to the toolkit and try to find ways to continue to get better and improve in some way and add something new.
Yeah.
It's almost like a Yogi Berraism, right? So
Yeah.
Well, it's also big for, not everyone likes this team, but I, as a, New Englander, it's a big slogan for the New England Patriots as well. So
for sure.
So we love that.
Absolutely, for sure.
And I was going to say, you're also preaching to the choir. You have a bunch of generalists here who'd see both adults and kids. So it's all the more you can do. I love it.
I would love to ask, what is a favorite failure of yours, something that you learned from in your career or otherwise?
Yeah, I think being okay with changing your mind. So I mentioned before that I initially went to Brown residency to do triple board, which is adult psych, child psych, and pediatrics. I did not complete that training. I kind of found another passion in another way. And in the process of it, it wasn't a failure in the sense that like negative things were happening, and I electively chose to get a program. But at the same time, it was like I came there for this, right? And then I'm making a conscious decision to not sort of do this. But it was end up being, actually a blessing to move in a different direction and be okay with that, and then see what other doors open up for you. So I think a lot of times, for learners and different learners, whether residents or fellows, sometimes they have a difficult time when they're kind of on this particular track or on this particular lane, but they find themselves being called and sort of moved to a different pulled in a different direction. That's okay, that's not a failure. That's you're pivoting, you're making the best choice for that particular time, and you pivot again. And if you find yourself being moved in a different direction, so I think that was a valuable lesson for me at that particular time in residency, to be okay with that, and then kind of take it for what it was, and get everything out of it, and still maintain great relationships and maintain the skills that I learned during that particular time, and still find ways to use those skills. So not to think of it as a waste of time, or find it as a way, find it as a situation where I made a bad choice coming out of med school in terms of doing that particular program, and ended up being a great thing. And it's pretty cool to watch some of the things I'm doing now in terms of mental health and GI work come full circle.
That's such a great lesson and story to hear. We do have a lot of learners who listen to this podcast, and being able to hear that, especially, we just finished a whole residency cycle, and, we have now fourth years who are looking at applying to residency, and which residency I go I'm going to make this choice, and it's going to be, the choice I'm going to have to take for the rest of my life. And I think they have to realize, and, the fact that you showed some courage to say, hey, you know what? I think I'm being pulled in a different way, than making that choice to actually do that shows that it can be done. So, people, you can make your choice for residency. If you find it's not working out well for you, you have to have the courage to, you don't have to be stuck with that with the rest of your life. So that's a fantastic
Absolutely.
Story.
Yep.
You want to get into it? Let's just do it. This is great. We are already off to a great start, but let's Sydney, let's start with this case. Let's be honest. No one starts a business for the joy of calculating tax withholdings. That's where Gusto comes in, to take the stress out of payroll, benefits, and HR so you can focus on why you started your business in the first place. Now, speaking from my own experience, when you're running a small business, the admin tasks pile up fast. Onboarding, paperwork, it all takes time. And when you're also busy working in the hospital, that time is something you just don't have. That's why Gusto is such a game changer. Gusto is online payroll and benefit software built for small businesses. It's all-in-one, remote-friendly, and incredibly easy to use, so you can pay, hire, onboard, and support your team from anywhere. They make things simple. Automatic payroll, tax filing, direct deposits, health and commuter benefits, even 401k plans. Gusto has it all. Gusto has options for nearly every budget, including unlimited payroll runs for one monthly price. No hidden fees, no surprises. So if you're like me and you want to spend less time drowning in paperwork and more time focusing on the work that really matters, give Gusto a try. Try Gusto today at gusto.com/Cribsiders, and you can get 3 months free when you run your first payroll. That's 3 months of free payroll at gusto.com/Cribsiders. One more time, gusto.com/Cribsiders.
All right, jumping in with a case from Cashlex Children's. So Abby Dahman is an 8-year-old girl with no significant past medical history who is brought to Cashlex Children's primary care by her father due to ongoing stomach pain. Her father reports that she has been complaining of intermittent belly aches for the past 4 months, mostly in the mornings before school and occasionally at bedtime. The pain is often described as a tight feeling around her belly button, but she can't really be more specific than that. The episodes last anywhere from 20 minutes to about an hour and don't seem to be triggered by any particular food. She hasn't had any vomiting, diarrhea, or notable weight loss. She continues to eat well overall, although her dad mentions that she sometimes skips breakfast on school days. Her energy levels are normal when she is playing with friends or engaged in activities she enjoys. However, on school mornings, she often has to stay home because of her abdominal pain. Her father has noticed that the pain seems to resolve when she's distracted or doing something fun. On exam, Abby appears well and is in no acute distress. Her vital signs are within normal limits, and her abdominal exam is unremarkable, no tenderness, no organomegaly. Her father is concerned about whether further testing is needed and whether this could be something serious. So let's jump in. Coach, can you tell us a little bit about terminology? What is functional abdominal pain, and then how is it different from irritable bowel syndrome or IBS?
Yeah, it's a great question. So when we think about functional abdominal pain, it falls under the umbrella of something called disorders of gut-brain interaction, which are disorders that are related to the nervous system of the brain and the enteric nervous system, which is the nervous system of your digestive tract. And there's a disconnect or miscommunication that happens between that nervous system of the brain and the nervous system of the GI tract. The nervous system of the GI tract is primarily responsible for how things feel and how things move. So there's a motor part and there's a sensory part. The motor part is like things can move fast, things can move slow, things can move forward, things can move backwards, things can move, contract, things can dilate. But there's also sensory parts: pain, nausea, the feeling of fullness, the feeling of distension and bloating. And so sometimes when patients have problems with chronic abdominal pain, they can have problems either with the motor part or the sensory part. So when we think about irritable bowel syndrome is chronic abdominal pain, typically daily belly pain that goes up and down, or it happens intermittently. And then there's some type of alteration of bowel patterns. So there's a sensory part with pain and a motor part that's also either diarrhea, things moving too fast, or constipation, things moving too slow. Take functional abdominal pain. Functional abdominal pain is chronic abdominal pain. However, you don't necessarily have the motor component of changing your bowel patterns. One of the other conditions that goes along with that is something called functional dyspepsia. When we tend to think about that, we think about that from the perspective of more upper tract abdominal pain, daily abdominal pain. But because it's upper tract abdominal pain, the other symptoms that go along with it are more like nausea, the feeling of fullness when you eat, and potentially sort of vomiting. And so they kind of all fall within the spectrum of disorders of gut-brain interaction. If you don't have any associated symptoms with the pain, we call it functional abdominal pain. If you have more nausea, vomiting, and it's more upper tract, we call it functional dyspepsia. If it's more lower, we call it irritable bowel syndrome.
So can you walk us through with our current case, what on this case makes you think this is functional abdominal pain versus something like IBS, and at the same time, does this need to be fully like a diagnosis of exclusion, or can I, pretty comfortably make that diagnosis based on this history and say if you do an exam that seems fairly normal?
Yeah, it's great. It's a great question. So, given the history of this patient, it certainly sounds like a functional abdominal pain type of picture. There seems to be a chronic daily belly pain that's happened, been going on for a long time. There doesn't appear to be any associated symptoms that go along with it, such as nausea, vomiting, diarrhea, constipation. It's sort of isolated belly pain that seems to have a very clear trigger for her, with school being a major trigger, which is actually very common, but it doesn't necessarily have to be school per se. When we think about, belly pain that's been going on for a long time, and we think about functional abdominal pain, a lot of times people think about it from the idea of being a diagnosis of exclusion. But the way that I like to think about it is that you can make the diagnosis just with the history. There's a few tests that you might decide to do because there's some overlap. When you look at a lot of the data that's out there, there's an argument to be made that you can screen for celiac disease with a TTG IgA and a total IgA. You can also screen for bowel inflammation with a fecal calprotectin. But when we start thinking about what causes belly pain, the way that I like to think about it for patients is really sort of think about it from the context, is this belly pain been going on for a long time? If the belly pain's been going on for a long time, then we put it into the category of chronic abdominal pain. Or what are some of the things that can cause chronic abdominal pain? You have inflammation, which you can do some screening things for. You can look for there could be potentially anatomy issues, but there's nothing here that suggests there's an anatomy problem. There can also be infection, but there doesn't seem to be anything that suggests infection, but it's on your differential. And then you start thinking about disorders of gut-brain interaction, and that's when you start seeing if there's any other associated symptoms to go along with it.
That's awesome. Actually, that's like the perfect workthrough of kind of how you'd approach this differential, regardless of the case. You were mentioning when you get into the gut-brain axis differential, we talked about three big things, right? Dyspepsia, IBS, and then in the middle, what we call functional abdominal pain. From a history perspective, does location of pain matter, or is it just the associated symptoms with each of the others that make a difference?
That's great. The location doesn't matter so much. I will say that most people, most patients, when you see them, when they talk about IBS, they tend to talk about more lower abdominal pain, but they certainly have generalized abdominal pain, right? But they may isolate things to kind of more crampy kind of pain. I will say from a location perspective, one of the things that might be helpful if there's unilateral pain, so pain on one side versus more generalized or bilateral pain. If the pain is more localized to one side, that might make you think about, is there some anatomical reason for that particular pain? Things like that. But for the most part, whether it's functional abdominal pain, irritable bowel syndrome, functional dyspepsia, the pain is typically generalized, although there may be some variation in terms of the pain maybe feel a little bit more epigastric or a little bit more lower or periumbilical, right? So
yeah. And is there any, just to kind of get from our history perspective, is there anything that we're missing that we should always ask about, any red flag syndrome, and not necessarily to diagnose functional abdominal pain, but to let us move towards that category versus saying, we should go down the IBD pathway or something along those lines? Anything that you're asking that we should know?
I think the big thing, and you got to highlight it in this particular case, is try to identify if are there any sort of triggers or if there are any ways in which the pain, when patients don't have the pain and they're distracted, is the pain distractible, right? So typically speaking, if there is organic chronic pain, the pain tends to not have many triggers associated with it, tends to be patients can't really be distracted from their pain, and there tends to be very, very clear association with certain types of things. When I eat food, I get significant diarrhea, or I get significant kinds of pain and things like that and stuff. And so it's always great to get a good holistic history, get a good social history. For a lot of our kids, there's a lot of pieces, there's a lot of associated conditions that go along with chronic abdominal pain. So a lot of the patients that I see in my clinic also have a history of anxiety or depression. They may there seems to be an epidemic of like POTS and EDS. There seems to be associated headaches. Headaches is a big way, and the way I talk about it with families and kids is that chronic abdominal pain, and in this case, functional abdominal pain, many times can be a physical manifestation of emotional distress. Right. And so the way that kids manifest emotional distress in a physical way tends to be either abdominal pain, nausea, or headaches. And so it's pretty common that there's nausea and headaches also associated with many of these conditions, but asking some of those other types of questions about associated comorbidities, as well as other triggers that may be playing a role to the pain and the symptoms can be incredibly helpful.
Just circling back to the distractibility for one second. Obviously, when I wrote this case, I tried to write it as a more classic example, but I do feel like I see a fair number of patients who just have this like abdominal pain with absolutely no pattern whatsoever. Based on what you're saying to me, as long as it isn't kind of hitting some of those red flags, or maybe yellow flags where it's unilateral or where there's a clear trigger from food or something like that, that can be functional abdominal pain, even if it's not, it only happens when they're going to school, and you can clearly associate it with an emotional trigger.
That's absolutely correct. So the trigger may not be clear, and the reality is that some people's triggers may be different at different times, right? And so sometimes it may be certain types of foods that may be triggering for them. Sometimes it may be certain social situations, school, emotions. Sometimes it's idiopathic. It just happens, right? And so helping patients sort of think about, okay, there's likely nothing catastrophic happening here, and then begin to use some of the tools that we use to help with the symptoms and also help with their functioning becomes incredibly important. And while you're initially they're presenting to you, it's okay to make that diagnosis up front, not necessarily feeling like you have to rule everything out before you get to that diagnosis. So you make a positive diagnosis up front. And then as you're making that positive diagnosis, you can say, I think what you're telling me, it sounds most likely like this. However, there are a few other things that kind of that overlap with this. And so I want to make sure it's not those things as well, but I feel confident that it's this. And then that way, if it ends up being that, then it's that, and you move forward with the treatment plan. If it's not that, you could always say, okay, hey, we ran some of those tests overlap. It's looking like we may need to do more assessments, whether it's endoscopies or ultrasounds or CAT scans or other types of things that may be going down the line of more organic disease in terms of inflammation or anatomy problems or things like that.
And you were saying something about the high comorbidity of these functional types of pain with other psychiatric conditions. So obviously getting a good history, talking about environmental stressors, things like that, and doing screening for maybe anxiety and depression and some of these other mental health type diseases. If they are positive for, say, anxiety, would you say that increases the likelihood that you're probably going to end up with functional abdominal pain as a diagnosis? Or say if they screen negative, do you feel that decreases your likelihood and pretest probability?
It's a great question. And so part of that is that what we know from the standpoint of it, I don't necessarily think of it in terms of it helps the pretest probability of the diagnosis being positive or not, because you can have organic disease and have there's a large number of patients with inflammatory bowel disease, for example, that also have IBS and have anxiety and things like that, right? And so just because they have anxiety or they have depression doesn't necessarily mean it's not something else, or celiac disease or those types of things. However, it does help from the standpoint of thinking about how the pain can be exacerbated and be exacerbated by the anxiety, right? Or how the anxiety can be also exacerbated by the pain, and it plays a role in terms of our treatment plan when it comes to functioning. So when we think about how we're going to address this, once we feel like we've come to a good diagnosis, we think about things from a standpoint of, okay, what are our goals of treatment? Our goals of treatment are improve function and reduce symptoms. Right. And so a huge part of that is getting a hold of, if there's mental health elements to that, that's going to be a core piece of how we're going to address some of the treatment. Because if we can improve some of the mental health aspects, so we can help reduce the symptoms, and we can also improve function. And that ultimately will get the patients getting better. And that's what we all sort of want.
Okay, so thank you for all of that information about the history taking. When we have a patient, in this case, or honestly any case, complaining of abdominal pain in front of us, I would love if you could talk a little bit about your physical exam, specifically the abdominal exam. If I'm being honest, I feel like I listen and then I kind of just press on their belly and see if they wince in certain spots. Like, can you help me make my exam more useful?
Yeah, it's so when we think about the part of the physical exam, the initial part of the physical exam is just looking, right? So you sort of look at the abdomen, and get a sense of, does it look distended to you? Does it look flat to you? Ask the parents, what is this close to their baseline? You're seeing them for the first time. And so some patients may come in, they may be really bloated that day, right? Or they may not be bloated that day, or that may be just what their baseline is. Oh, this is what it normally sort of looks like, or this is what it looks like in the morning time, but they haven't gone to the bathroom yet. By the end of the day, or vice versa. Sometimes it's super flat in the morning, and then by the evening time, they get really bloated after they've been eating all day, right? And so asking them, okay, just looking at their belly, what is this close to what their belly normally looks like at this particular time of day? And so that's I think the first step in terms of the abdominal exam for patients. Then after that point, there's a palpitation sort of part of it in terms of listening to the 4 different quadrants, making sure you hear good bowel sounds, and then or auscultation, I should say, listening. It's an auscultation part of it where you're listening for good bowel sounds, and then I like to feel all the 4 quadrants. You're feeling for organomegaly. You're looking to see if there's any type of masses, whether they're firm masses or mobile masses like stool and things like that, that are in there. And then you get a sense of how tender or how sensitive the patient might be. If you just barely are touching the patient and they're kind of jumping back, or they're already complaining of pain before you touch them, that means there may be a sense of some allodynia, right? And so we see that in patients that have visceral hypersensitivity, where the nerves are just kind of hypersensitive, and many of the kids with functional abdominal pain or irritable bowel syndrome, or are they really tense and anxious, and kind of get a sense of how they are, their dispositions, and in the midst of doing the abdominal exam. I like to have my patients lay down flat on their back during their belly exam. Sometimes, depending on the kid, you have to kind of get in where you fit in with kids. And so depending upon the situation, they may be in a wheelchair, things like that and stuff. So you have to kind of do the best you can sort of do, maybe recline the wheelchair back a little bit and things like that. You can get a sense of, if their abdominal core is like tight, you can get a sense of, does it feel nice and soft, compressible, things like that, like guarding, those types of things. But typically speaking, for functional abdominal pain, they may be, on an exam, you would expect to have normal bowel sounds. You would expect to have not any particular, localized pain. You'd expect the belly to be nice and soft. There could be variation in terms of how distended the belly is, but most of the time the belly is relatively flat. And then there tends to be just some generalized tenderness when you sort of press the belly, and it somewhat depends on how they're feeling that particular day.
Awesome. I actually think that's really comprehensive, because it sounds like, I was going to ask, does it matter in the sense that they could be having pain or they can not be having pain at that moment? And it sounds like that it's not going to really matter at the end of the day. But these are some of the other things that you would expect to see, like a soft abdomen. They should not be tense. They should not have some of those other things. I do want to get a little bit to workup because I have some specific questions. So maybe we'll just take this step by step.
Sure.
So let's start in the beginning. Are there any tests? So the patient here, Abby, is a good example of someone who's like clearly not having any other symptoms, and we just have pain. So let's take her, which would hopefully be our classic case. And is there anything you would universally do for all patients when you're concerned about functional abdominal pain, still at the highest of your differential, but you want to rule some other things out? Are there any? And then we'll kind of start changing the case up a little bit and start adding some curveballs.
Sure. Yeah. So, but the two tests that I end up doing for patients for they come in with belly pain is I screen for celiac disease. So I get the TTG IgA and the total IgA if they haven't had that, and then I also get a fecal calprotectin. And I'm doing those to look for celiac disease and for signs of bowel inflammation. So fecal calprotectin is not necessarily specific for IBD per se, but it is specific for bowel inflammation. And so that will help guide me in terms of making a decision about do I need to do other testing, like endoscopies or colonoscopies, things like that and stuff. If those two things are normal, then I feel pretty confident about not necessarily needing to do other tests unless there are other signs and red flags that may be suggestive of looking for other types of things. The reality of the situation, however, is that many patients end up coming to me and they either have had a pretty large workup or they're coming as a second, third, fourth, fifth opinion and things like that. And so their cases are sometimes not as straightforward necessarily. And so you might end up doing other testing, basic lab testing, a CBC, liver panel, maybe an ultrasound, things like that. But those aren't necessarily universal tests that I would do. I would say the two universal tests I would do for patients that come to me with chronic belly pain, if they haven't had these tests done, would be the fecal calprotectin and the TTG IgA with the total IgA.
Awesome. Maybe the way you're describing the patients come to you, maybe I'll just flip the way I was going to do this for a second, because I was going to go by symptom, but I actually think, for example, if you're already going to be screening with a fecal calprotectin, you're already looking for inflammatory bowel disease no matter what. You probably already get to look for infection that way, because if that's positive, you can also be a little bit concerned about infection. So let me flip it and ask you, when would you do anatomic testing first? And then we can say, when would you scope somebody?
Yeah, it's great. So the anatomic testing, so typically speaking, do anatomic testing for chronic abdominal pain. My test of choice, if I was going to do a test, would be an ultrasound. I tend to be more conservative in terms of, I tend to be more conservative in terms of I don't necessarily, if I don't necessarily need to do MRIs or CAT scans, try not to do those in kids if you don't need to, right? And so you can do an abdominal ultrasound, just kind of just a full abdominal ultrasound, and that might be helpful. The situations I would do that is typically in cases where the pain has been refractory. They've already had a pretty good workup in terms of they've had scopes done, they've had other lab tests done, and there's no clear answer. There's kind of in there, and you've gone down the road of trying to treat their belly pain. You've done a lot of the different things, and the symptoms are still persistent. I tend to not necessarily do an ultrasound up front. I tend not to do an ultrasound as part of my general kind of workup, just to make sure there's no anatomical reason as to why they're having pain. And sometimes you can find some unusual things. The other piece, if there's other comorbid symptoms, not just sort of isolated belly pain, but they're starting to have their symptoms change a little bit. They're starting to have some nausea, starting to have some vomiting, things like that. Maybe there's some focality to their belly pain. Maybe something has changed in their history over the time I've been seeing them that maybe sort of me think I need to sort of think about my diagnosis a little bit differently. Something might have changed.
Would there ever be a use for KUB when we're talking about imaging?
So the KUB is done a lot of times for the purposes of making a diagnosis of like constipation, I would say, or fecal load. And you don't need to do a KUB to make a diagnosis of constipation. You can use the history, right? And so how we define constipation is hard, painful stooling less than 3 times a week typically, and incomplete evacuation. And so when they go to the bathroom, everything doesn't necessarily come out, but they still feel like there's still stuff stuck in there. Now, it can be helpful if you think that the chronic abdominal pain is related to constipation and you want to get a sense of what is your current fecal burden, right? What is your current stool burden, right? And that might help you make a decision about a patient needing to do a clean out or something like that. But once again, for the diagnosis of functional abdominal pain, you do not need to do a KUB. You do not need to do an ultrasound or a CAT scan or MRI or even a scope for that matter to make the diagnosis of functional abdominal pain.
And so that's kind of where we talked about anatomic testing is where you would go for the ultrasound. Where would you then proceed to go for an upper or lower endoscopy?
Yep. So typically speaking, in the sense for a lower endoscopy, typically the way I sort of end up doing my workup, if the fecal calprotectin is elevated, I will go and do a lower scope. Many times I also do an upper scope at the same time because there may be signs of inflammation. However, just because it's abnormal doesn't mean that you're going to have actually bowel inflammation. But I need to look. There's at least there's enough of a signal to potentially sort of look, and you have pain, and you're coming to see a gastroenterologist, which you've already seen your primary care doctor at that point, and it's obviously affecting your life enough to need to see specialists. Sometimes I'll do just an isolated upper scope. If the TTG IgA is elevated, I'm worried about celiac disease, and the fecal calprotectin is normal, I'll just do an upper scope. I will try to, at least initially, not necessarily move to a scope right away if a patient just has isolated belly pain, and try to, move into like, hey, I think this, based upon your symptoms, we do a little bit of screening labs. You have a normal TTG IgA, you have a normal fecal calprotectin. Let's begin to start working towards symptom reduction and improvement of function. And if we're making progress, or if we're stalling in progress or not making much of progress, then I'll go ahead and move on to doing an upper endoscopy. Unless there are other symptoms at play, like the patient also has vomiting to go along with it, or they have they have other types of symptoms, a localized type of symptoms. They're complaining of a lot of epigastric pain, or they're complaining of like chest pain, things getting stuck, dysphagia, adenofacia. There are other symptoms that go along with it. Then I would go and do a scope pretty early on. Not necessarily just if it's just generalized belly pain that's been going on a long time that's distractible. Distractible, but it only happens when they're in school and things like that and stuff. So.
Awesome. So it sounds like, we first really try to differentiate based on symptoms. And if we do have upper symptoms, we can go for an upper scope. If we have lower symptoms, it doesn't change so much in the sense that we're still getting a fecal calprotectin. Fecal calprotectin is abnormal. You're going to search for it. Just from a gastroenterology perspective, I know a lot of people, if they have an abnormal fecal calprotectin, they'll also want to make sure that there's no infection there. Do you ever do that? Or are you always seeing patients who have chronic pain? And so therefore the idea that they have acute infection seems incredibly unlikely?
It's a great question. So typically I will end up doing infectious stool studies in the setting if they have diarrhea, right? And so if there's no diarrhea, then I typically and they have chronic belly pain, I normally don't get infectious stool studies. Or if there's diarrhea or blood in the stool, I should say diarrhea or blood in the stool, I'll get infectious stool studies in that particular setting, because you might have a slightly elevated fecal calprotectin, for example, and it may be something like a polyp that's causing that, or you might have had a viral infection just recently, and then it caused your fecal calprotectin to be elevated, but I wouldn't necessarily do anything with that viral, like if the diarrhea is all resolved and stuff, and then now I'm sort of stuck potentially to sort of do, what do you sort of do with that information necessarily? So I don't necessarily test for that per se, but if there's no diarrhea, I won't necessarily do infectious stool studies. There are other infections that sometimes that may play a role that we can see also on the scope that can be helpful from an upper scope standpoint. So if a patient has like dysphagia or dynaphasia, they may have fungus in the esophagus, right? So that'd be a reason to do a scope. I wouldn't do an infectious workup until I did the scope. Or if I'm looking for H. pylori, sometimes patients have belly pain and gastritis related to H. pylori. I would actually want to diagnose that with a scope, not necessarily with the stool H. pylori test, which I know that it exists. We tend to not sort of do that test necessarily. We want to diagnose that with the scope. But once again, those situations, the patient wouldn't have diarrhea. And if patients having ongoing symptoms, I would already be moving forward to doing the upper scope, and I would potentially sort of be able to diagnose that during the upper scope.
And I have one last question before Sydney moves on to our next component here. What tests am I missing? Is there anything else that we forgot to ask you about from a testing perspective? And I love your breakdown, by the way, and I love this standardized approach, because we as primary care and generalists can do at least the first half before we get to the endoscopy, so to speak. So yeah, any other tests before we move past testing?
Yeah, so I'm a less is more when it comes to testing. So I like to get a great history, and then start thinking about how do we get you feeling better?
Great.
All right. So we've done, at least some degree of workout, probably just the minimal workout in this case, and it's coming back normal. I would love to just hear your script, which I think you've been weaving in a little bit, but I would love to hear just the full on, what do you say to a parent and to a child when you are saying, I think that this is a disorder of the gut-brain interaction? How do you explain that?
Yes. So what I end up saying is that, thank you for coming in. Go see me. And so I'd say, when we think about belly pain, we put it into two different buckets. We put it into acute belly pain, and belly pain's been going on for a short period of time, and belly pain that's been going on for a long period of time. We use those two buckets to help us determine how invasive we need to be in terms of our initial sort of testing. If it's in belly pain that's been going on for a short period of time, we think about doing certain types of things versus belly pain that's been going on for a long period of time. It doesn't necessarily mean one is more important or more serious than the other. For example, if you can have belly pain that's been going on for 2 days, that it could be just a GI bug, it could be appendicitis, right? One requires surgery, one requires time, right? Versus you have belly pain that's been going on for 2 years, right? It's most likely not appendicitis. And so families kind of get this sense of that. And I want to make sure I don't want to minimize the seriousness of what they've been going through, because when you have a kid that has chronic belly pain for a long time, it has a dramatic effect not only on the kid's life, but the entire family's life, right? And so then once so now we've established this chronic belly pain. Let's look at the four major ways or four major areas in which reasons kids will have chronic belly pain. And so we start with inflammation. Is there any kind of inflammatory component? We may do a certain test to look for that, fecal calprotectin, TTG-IgA, things like that. We look for anatomy, potentially it could be anatomy issues. Then I say it could be infection. And the fourth one, which actually is the most common reason why patients have chronic abdominal pain, it has to do with this disorders of the gut-brain interaction, how the brain is communicating with the gut, the nervous system of the brain and how the nervous system of the gut are communicating with each other. They normally communicate with each other in a way in which it allows the gut to both feel and feel certain types of things, and also move the way it needs to sort of move. However, sometimes there can be a disconnect. And when that disconnect happens, it causes patients to have symptoms. When they have symptoms, they can be sensory symptoms, it can be motor symptoms. And sometimes we think about it from the perspective of what are some of the things that could be potentially sort of causing that disconnect. Sometimes it can be infection. Sometimes it can be food. Sometimes it can be emotional distress. Sometimes it can just randomly happen. And sometimes it can be things like, not necessarily emotional distress in the sense of, they're feeling really anxious and worried about something very specific. It can be just life things, just the things that they have to do because they have a lot going on and whatnot. And so school many times for a lot of kids is that primary stressor, a primary stressor. And school's a lot different for families. A lot different for kids nowadays. I feel like, it's a lot of stress related. So it's a lot of stress. Social media plays a big role in some of this. And so we have conversation around that.
And so say if I'm a teen, I'm like, Coach, you're telling me this is all in my head? Like there's something wrong with me, but you're just telling me it's in my head? How do you respond to something like that?
Absolutely. So what I say is that, so your pain that you feel is absolutely real. You have real pain. What we're saying is that the brain is perceiving that your gut is sending a signal to your brain, and the brain is perceiving that signal. Something is wrong, right? So your gut is doing all this sort of normal types of things, but it's sending this distress signal. Something's wrong, something's wrong, something's wrong, something's wrong, something's wrong. And the brain begins to be hyper fixated and becomes hyper focused on what's going on with the gut. And it becomes this vicious cycle that's really difficult to sort of break. Your brain becomes hyper, your gut is saying there's something wrong, there's something wrong, there's something wrong. Your brain's okay, what's wrong? And you can't break it. And then there may be certain types of things that make it worse, but it's always there. And your pain is always there. It's very real pain. The signal is constantly happening, right? And then you have different things that kind of tip you over, and that's why you have some good days. That's why you have some bad days, right? And then the patients normally can typically understand that from that perspective.
This is just like the part, like you just keep, we got to break the cycle. We got to break the cycle. We got to break the cycle. I just feel like the transition is so good that we can't miss this to talk about treatment right now. So you just put up this cycle, and then what we need to do is talk about some treatment. So what are you telling them? How are we going about this? I'm sure it's a multi-pronged approach. Can you kind of take us through your diagnosis? We'll say that we've diagnosed Abby officially with functional abdominal pain, just to be very specific.
Absolutely. So when we think about treatment, the first thing we have to think about is treatment goals, right? What are our goals of treatment? Our goals of treatment into it first, improve function. It's always function first, right? So and when we talk about improving function, we're talking about everyone's function is going to be a little bit different than others. For some people, improving function means being able to go to school. Some people it's being able to hang out with your friends. Some of it means returning back to your sports. Some is just being able to eat a meal. Everyone's function is going to be a little bit different. Then we also talk about symptom reduction, right? So while we're working on function, improving function, we're also working on reducing symptoms. For many kids, they feel like, well, doc, if I felt better, I would do more. But it doesn't work. It doesn't work that way, right? And if you sort of wait until you feel better to do more, you find yourself deeper into a hole, and it becomes more difficult to actually do more stuff. So we want you to actually function. And while you're working on function, it's our job to help come up with different ways, give you skills to help you function better, but also give you different tools and give you different strategies to help reduce your symptoms. So then how do we go about reducing symptoms? How do we go about improving your function? We really put things in sort of three different buckets. The first bucket is we think about medications, right? And the reality is that the data suggests that most medications don't work great for chronic abdominal pain. And unfortunately, that's been the experience of a lot of the patients that I end up seeing, and we commiserate over that. And we say, like, right, you've tried stuff, right? And like, yeah, like nothing's really helped. It's like, yeah, nothing really helped. You're not alone. That's most people's experience. That's most people's story. Now, if we find there are some medications that are out there that we do use that can be helpful, but for the most part, most of the medications are not particularly helpful. If we have a medication that's helpful, as long as it's not causing too many side effects, we'll use it if it's helpful for you. And there's a couple of medications that we potentially will sort of use to help with some of that. Some of those work on antihistamines. Some of them work on various different neurotransmitters, like it's using TCAs. There may be other ones that we use as antispasmodics to help with kind of like symptom control, things like that. If there is other components like nausea or diarrhea or things like that, even though that's not typically in your functional abdominal pain specifically, we can use different medications to potentially sort of help with those. So that's our medication bucket. The next bucket we talk about dietary, or I talk about dietary changes. And the reality is that, once again, there's no specific diet that has been sort of slam dunk proven. This is the diet to do if you have functional abdominal pain. There are some suggestions of things you can try to help with dietary help from a dietary perspective. So reducing simple sugars. There are specific types of diets that you might try. Many times they're hard to sort of sustain, but you can try, or you can just try to reduce the amount of sugar intake that you're doing. That might be helpful for some people. There's some data out there that may suggest doing a Mediterranean style diet might be helpful for people. There's some suggestions that maybe that red meats can be pro-inflammatory in nature, so reducing the amount of red meat that you eat may be helpful for some folks. There's some thoughts about processed foods having emulsifiers in them, and emulsifiers being pro-inflammatory and affecting the gut, and so reducing the amount of processed foods that you're eating might be helpful. There are foods that you can avoid that may serve as triggers. So, for example, dairy. So some folks, they may not have true lactose intolerance or a true milk allergy, but when they eat dairy seems to trigger their symptoms. So then you can remove dairy from the diet, and that might be helpful for them. Gluten is another one. You may not have celiac disease, but you may have a non-celiac gluten insensitivity. And so you can remove gluten from your diet and your symptoms might get better. So when it comes to dietary things and elimination of certain types of foods, my answer is you can remove foods that seem to be problematic for you as long as the answer is you're just removing food. So you still want to have a well-balanced diet, but if there are specific types of food that you feel are triggering for you, you can remove those foods as long as you have a well-balanced diet. Then there are also other types of dietary things that might be helpful to help with other symptoms. So, for example, peppermint is a natural smooth muscle relaxer. And so many times patients, they'll actually incidentally find that I go to the school nurse and I ask for a peppermint and it seems to help my belly, right? And so there's a physiological component to that in terms of peppermint helps the smooth muscle that lines your intestines relax, and it may be helpful for abdominal cramping. Ginger has been shown to help with nausea. And many of the patients that we have chronic abdominal pain also have nausea. And so that might be helpful for some people. I find that many patients don't necessarily like to eat their ginger, but they will drink their ginger. So ginger teas, ginger mint, things like that can be helpful from a dietary standpoint. And there are other supplements that folks might use. There's questionable data in terms of how beneficial probiotics are for chronic belly pain. The data is not particularly strong. The data says that they probably don't help, but they probably don't hurt. The most recent data I've seen says you can try them if they are helpful for you. And so that's kind of how I leave it with families. But I don't necessarily recommend, I need you to be on this probiotic because the probiotic is going to help your chronic abdominal pain. And then the third bucket, so we have pharmacologic things, dietary things, and we have non-pharmacological things. And so in that bucket, we spend a lot of time talking about what are some of the things that we sort of treat, or what are some of the things that fall into that bucket. So working with psychology, specifically GI psychology, is incredibly helpful, especially using things like cognitive behavioral therapy to help with that pain cycle between how the brain and the gut are communicating with one another. So most of the time, the patients are looking at me like, psychology? Oh, wait, I thought you said this wasn't in my head. Now you're telling me I have to go see a psychologist. Wait a minute. And it's like, no. So when we think about it from the standpoint of the brain, the nervous system of the brain and the nervous system of the gut are incredibly similar to one another. And so we can use a lot of the same treatments to treat the same similar pathways. For the example that I would give is say, for example, if you were to hop off the table, let's say, for example, you hopped off the table and you turned your ankle and you sprained your ankle. What might you take? And they go, oh, I don't know. Tylenol, ibuprofen. Like, great answer. Let's go ibuprofen. Perfect answer. So you take your ibuprofen, you head home, you turn the corner, your dad turns the corner, you guys crash heads. It's been a long day. You had to listen to me talk nonstop. You sprained your ankle in my office. Now you have a headache. It's been a rough day for you. But what might you take for your headache? And they'll say, oh, I don't know, ibuprofen? Perfect answer. And so you took ibuprofen for your sprained ankle. You also took ibuprofen for your headache. Different location, but the pain mechanism is very similar to each other, so you can use the same treatment. That's how we use cognitive behavioral therapy, and that's how we use the psychology. While yes, it's very good for anxiety and depression, mood disorders, it's also really, really good for chronic abdominal pain and also nausea as well.
I like that. I
really like that discussion. Yeah.
Patients and families really buy into it when I break it down that way. And that seems to work really well. You can also many times refer patients to abdominal physical therapy. So physical therapy is sort of focusing on the gut and kind of improving the core, and really it's really sort of a almost an advanced way of distraction in a way, right? So the brain is so hyper focused on the gut. If you start moving the body in different ways and kind of strengthening the core and also doing other types of things, it forces the brain to think about other stuff. And it doesn't become hyper fixated on kind of the signal that's coming from the gut. Along with in the psychology realm, there's also like the use of guided imagery, which is another form of like a higher level of distraction, so to speak, where you can really sort of focus in on just sort of helping reduce anxiety and reducing kind of that pain gate that's happening, or help patients sort of work through when they're having amplified symptoms. And the big thing that we're doing now that's kind of becoming really state of the art and kind of the standard of care for many patients with ongoing belly pain is using neuromodulation. And so there's a device that's out there that you can put on your ear. You have nerves that come from your brain that dive down into your gut, innervate various different nerves. One of the major nerves that it innervates is the vagus nerve, which plays a significant role in your autonomic nervous system and a lot of your sort of gut physiology. And you can actually wear this device over a period of time. And what the device does is stimulates that brain-gut connection, right? And it desensitizes that brain-gut connection. And the example that I like to give is that, I like analogies. So the example I like to give is, I tell the kids, imagine you're in a car and you have the car radio, and you can turn the radio up, you can turn the radio down, right? And so if your dad's music is playing, you want to turn that down, right? If your music is playing, you want to turn it up. So imagine your car is your dad's radio station up all the time, and you can't turn the music down, right? And so and the dial is broken, and it's always turned up. Right. And so what we try to do with this device is desensitize that system. Right. And so we send this electrical signal to down-regulate that system, to reset the system. So now you can get back to turning the volume down. Right. And so it doesn't mean you'll never feel pain again. It doesn't mean you'll never hear your dad's music again, but it does mean that you can modulate it. Right. You can turn it up, turn it down. So you're not always in pain. Or you're not always having nausea, because we also use it off-label for nausea as well. And so we use that particular device to help with chronic belly pain, especially for patients that have refractory symptoms, that have tried other types of things, that will come to us to down-regulate that gut-brain pathway.
Awesome. This was the biggest overview, and we're going to hit this a little bit more specifically, but this is fantastic. This is so good. This is so good. So we got three buckets. We got our meds or a pharmacologic therapy. We have our dietary, and that includes supplements as well. And then we have our third one, which is non-pharmacologic, which includes more of the psychotherapy and some of the biofeedback and neuromodulation type pieces. Let's just take each of them in order for a second, because we have follow-up questions for all of them. So we thought we'd just go kind of in order. So let's start with the pharmacologic, the meds. Yeah, they're not that great, but sometimes people go to doctors looking for medications. What are the meds that you would generally prescribe, even if we know the efficacy is going to be relatively mediocre?
Yep, absolutely. So first thing I sort of do is first looking at medications. How frequently are you having symptoms? Right? If you're having symptoms that are happening just kind of intermittently, they're not necessarily daily per se, but they happen frequently enough that it kind of get in the way, and they maybe they may self-resolve over time. Then maybe you just need something that's more of like a as needed type of medication. And then you can use more of your antispasmodic types of medications that you can use on an as needed basis. And so that will look like something like dicyclamine, that's some hyoscine, those medications to help with kind of spasms and help with kind of pain can be helpful. A supplement that I kind of put in there is technically not it's not a prescription-based medication, but it kind of falls in the supplement realm that also I use it as a PRN is, I don't know if I can say a brand. I guess you can edit it out. It's IBGuard. But
I was going to bring it up.
I'm not sure if I'm allowed to say that or not. But
there are only so many other supplements that are similar to IBGuard, so I think that's very reasonable.
Yeah. So IBGuard kind of tends to work on more upper GI tract pain, and there's also FDGuard that works on more upper GI tract kind of pain. So I'll have patients, they can use them interchangeably depending upon where they feel like their pain sort of is, and they can use that either in addition to the antispasmodics, or they can use that instead of, because some families don't necessarily want to use prescription-based medication and prefer more holistic type of supplements. But I kind of put that in the supplement bucket because I use it as a PRN, as an as-needed type of medication.
So, like IBGARD and FDGARD, I know that both of them have multiple ingredients in there. Last time I looked, I think a major ingredient for both of them, at least, is the peppermint, which you sort of brought up already. And I think it's sort of like a dose that often is hard to get to a certain amount of peppermint that you've seen in a lot of studies. What is the other major differences between like FDGARD and IBGARD?
Yeah, so the IBGARD has peppermint and menthol in it, and the FDGARD has caraway oil and menthol in it. And so with peppermint relaxes muscle. One of the problems with peppermint is that it can make reflux worse. And so the lower esophageal sphincter, it can relax the lower esophageal sphincter, right? And relax the lower esophageal sphincter, and it causes people to reflux more. So sometimes when people take peppermint, they will complain that they have really bad reflux. That's a real thing. So patients that have more upper tract, the kind of dyspepsia type of symptoms, it doesn't have the peppermint. And that's why one is more FD-GARD, so functional dyspepsia GARD, versus one is more IB-GARD, which is more IBD GARD. Functional abdominal pain. There's no FAP GARD. So at least not that I'm aware of. And so because where patients' symptoms might be, there becomes some variability to where their symptoms are. I give them both options because sometimes they feel like it's generalized, but sometimes they feel like it's more, it's more lower, it's more upper, or like it's worse when I eat, things like that, or I have more like cramp, and so I give them an option of both, and they can kind of test out and see which one works a little bit better for them if they want to use it on an as needed basis. Those are the as needed ones I typically sort of use. Then there's the ones we use more on a daily basis. So one of the ones we use on a daily basis is cyproheptadine, which is an antihistamine. Typically, we'll use it either once a day or twice a day, although it can be used 3 times a day if necessary. And that medication, I think, works really, really well for patients. Typically, I use it for younger patients or patients that are a little bit lower weight, because one of the side effects of it can cause some weight gain because there's an appetite stimulation component to it. And many times we use it in the GI world for appetite stimulation. But the cyproheptadine can be really helpful for chronic belly pain. The other medication I'll also use is amitriptyline. We tend to use that. I tend to use that in maybe a little bit older patients, although you can use it in someone like 8 years old, like in our case. But I tend to use amitriptyline as well. Amitriptyline takes a little bit longer to really kind of get into the system. I think it has more of a side effect profile than compared to, say, like your cyproheptadine. And so I talk about the black box warning with it. I talk about the other side effects: constipation, blurry vision, some of the cholinergic effects that it has, things like that. There also can be a weight gain component to it as well. At really high doses, when amitriptyline was really used as an adjunct as an antidepressant, you could see some cardiac changes. And so while consensus is you don't necessarily have to get an EKG prior to starting amitriptyline, I tend to get an EKG, a baseline EKG on patients that I'm going to start amitriptyline, but you don't necessarily have to do that per se. And so I use that medication. And then my third one that I tend to use, if I don't use the cyproheptadine or the amitriptyline doesn't work, then I might move to something like gabapentin to help with some chronic pain.
And so, of those 3 doses, those are all what we would consider not off-label, but used for different indications they were initially created for. And these medications all have different kind of dose therapeutic ranges that yep. sometimes differ based on this. So I was just curious, cyproheptadine, amitriptyline, and gabapentin, what are you going for your therapeutic range, or what are you trying to get up to as far as your dose is concerned for each of those? If you kind of give us your rough just in case we wanted to start them ourselves.
Sure. So for cyproheptadine, I will typically go 4 milligrams twice a day. It typically does trick. You can go higher than that, and I think you can go up to like 16 milligrams for that medication. But I rarely go up to 16. I think that I might add a middle day dose and get to 12. So I'll do 4 milligrams, 3 times a day. But for the most part, I typically land at 4 milligrams twice a day with cyproheptadine. When it comes to amitriptyline, there's a lot of variation in that medication depending on what you're using it for. My neurology colleagues tend to be a little bit more aggressive than I am when it comes to using that medication, especially for headache management, things like that. I typically will cap out at about 50 milligrams. The reason being is I feel like the side effect profile for belly pain, the side effects begin to start outweighing the benefit I see for belly pain. From my experience has been that if they're not going to get better up to 50 milligrams, then the amateur is probably not going to help their belly pain. It might help other things, so they may be there on it for other reasons and stuff. But for the purposes of belly pain, I typically will start anywhere from 10 to 20 milligrams, titrate up within 2 weeks, hold it there for about a month. It takes about 4 to 6 weeks to really get a sense if it's really helping or not. And then I pretty much will stop at about 50 milligrams for patients. And I rarely even get to 50 milligrams. I think I may most of the time I end up landing somewhere between 20 and 40 for many patients. And then for gabapentin, that one's a little bit of a moving target. Really more so, it's kind of the main sort of variation for me is like how often I'm giving it, right? And so there's a slow titration you do with gabapentin, especially if you're doing it as an outpatient. And then for most patients, I'll normally end up doing about twice a day. I tend to not use gabapentin very often. There are cases that I will use it. I tend to pretty much stay with ciprofloxacin and amitriptyline. And if I really feel like a patient really needs gabapentin for the purpose of treating their chronic pain, then many times I'll end up having them. I'll check in with our not check in. I'll have them also see we have a chronic pain team that also has some other therapies that they may also do in addition to some of the medications and things like that and stuff. So.
Whether this is your first episode or you've been with us since day one, you know our goal has always been to share clinical pearls and practice-changing knowledge about core topics in pediatric medicine. So let's talk about something that actually changed my day-to-day as a pediatric hospitalist. FIGS. I can't walk into a clinic or hospital without seeing people in FIGS scrubs. And I get it. I wear them too. They're incredibly soft, form-fitting, and durable. And it's not just us. If you've been watching a certain popular emergency room drama on TV, maybe based in Pennsylvania, yep, they're in FIGS too. These scrubs get it. That's what drew me in and what keeps me coming back. And because we work with kids, and kids come with messes, I love that FIGS are antimicrobial. When stuff gets on your scrubs, and it will, you just wash them and they come out wrinkle-free. I've washed mine over 50 times and they still look brand new. Now, with the holidays right around the corner, it's a perfect time to treat yourself to some fresh looks for the new year. Which is great because FIGS just dropped a ton of new limited edition colors and styles for this season. And so Cribsiders listeners, if you want to check them out, FIGS is offering 15% off your first purchase at wearfigs.com with the code FIGSRX. That's wearfigs.com, code FIGSRX.
So one thing I've heard a lot, especially when we're talking about like the gut-brain interaction, is talking about serotonin, a lot of serotonin in the gut, and one groups of medications that I see often is talking about SSRIs or SNRIs. Is there much evidence in that use in our pediatric populations? Do you ever use it?
So 95% of your body's serotonin receptors are made in your EC cells, which are in your gut. And so the gut serotonin is a huge part of gut motility and part of helping your gut move and helping the nervous system of your gut do the things it needs to sort of do. And so there's been a lot of different studies about the use of SSRIs for the treatment of belly pain, with citalopram probably being among the most common used for belly pain. The data out there for citalopram for the use of chronic abdominal pain, it doesn't seem like the data doesn't necessarily support the use of citalopram as a primary for the treatment of chronic abdominal pain, as the pain being the primary endpoint, or reduction of pain is the primary endpoint. Because there's so much overlap with like mood related things, you might end up helping the belly pain because you're also helping the anxiety and or say depression, right? With that being said, anecdotally, you will find many providers that have had success using citalopram to treat belly pain. There's a couple other SNRIs that might also be helpful when you have that dual component of both there seemed to be some pain modulation component, and also there's significant sort of mood related stuff. And so many times when I have patients that I think that anxiety is playing a role or depression is playing a big role in their pain and how they're perceiving pain, then I'll have them work with either their primary care doctor, their psychiatrist if they have one. If I'm thinking that, you know what, this patient might actually be better off being on an SSRI, I might not start amitriptyline because I think that the mood is actually playing a huge role, or the anxiety is playing such a huge role that actually they'd be better served on starting an SSRI than actually starting amitriptyline, because there's actually a lot of drug-drug interactions. And so I was having to go back and say, okay, if they have a psychiatrist or they have a primary care doctor, talk to your primary care. I think that your anxiety is playing a big role in this. We're going to hold off on starting the amitriptyline because then it starts getting muddy with drug-drug interactions and stuff. Especially if I'm already questioning whether the amitriptyline is going to be helpful anyway. And I think overall, the main driver of a lot of your symptoms have to do with kind of where your mood is at, and where your anxiety is at. Let's treat that along with doing the medications, while still also working with psychology and doing using kind of combo therapy, and see if we can reduce the symptoms that way.
And just a quick follow-up, because Sydney's going to jump in at the chance to talk more about the diet. When you add, or when you go from ciprofloxacin to amitriptyline to gabapentin, are you removing the prior one and exchanging the drug, or are you adding the drug?
I'm typically removing one. I'm removing.
Okay, great.
Yep.
Great. All right, Sydney, go for it.
All right. So moving on to your next bucket, the dietary supplement end. You provided a lot of really great thoughts about things in the diet that may contribute, right? You were talking about reducing simple sugars, avoiding red meats, that processed foods may have emulsifiers that are pro-inflammatory, dairy, gluten. Obviously, that is a lot to bring up to a patient at the same time. So I'm curious how you frame it. Do you say, okay, let's do a X number of week trial without this thing? Do you have them just work with a dietitian and say whatever the dietitian says is what you're going to do? Like, how do you frame, or you say, you know what, no one needs processed food, so let's cut that out and do these 3 other things. I would love to know how you structure those trials, because that's something I feel like I'm constantly struggling with.
Yeah. So I will say, when it comes to medical decision making and opinions about treatment course, their dietary ideas, suggestions, parents have the strongest feelings and also the strongest expertise in that in that area, more so than any other area of GI, I feel like. And some of that may be sort of warning me. A lot of families like have actually strong background in dietary things and they certainly know their kid, how their kid responds to dietary things better than you are just sort of meeting with them. But their families have a lot of strong opinions about what they want to put in their child's body when it comes to foods, how much of what they do and don't want to put in their child's body. And so I respect that. Some of that is culture related. Some of that is just like their history. Some of that based on their education. Some of that is just based on just like medical kind of preference, right? Because, food is medicine in some respect, right? And so one of the things that I sort of do when we talk about dietary things, I like to get a feel for where the family is in terms of, I mentioned a lot of different dietary things, because what I've found is that parents have strong opinions about it. And so I'll ask them, based upon some of the things that we've talked about, do any of these things resonate with you? Many times they've already tried some of the things, or have you tried any of these things? What are your thoughts around the role that the diet or dietary things might be playing a role in your child's abdominal pain? And it just opens this door up to just a great conversation. Maybe sometimes, a little bit of addressing some myths that may be out there, or just kind of getting insight into how they sort of think about dietary stuff, and really using diet as a medicine. Sometimes that ends up being where we end up landing, and the families really want to focus in on and that's really the real reason why they end up coming and seeing me. After all the talking we're doing, all the different things we're sort of doing, we end up really talking about, how can I manage this with diet? I don't want any of that stuff, those crazy medications you were talking about with these weird side effects that don't help. You're talking about some weird ear device and talking to psychology. I want to know, what can I feed my kid and what can I sort of do to actually help them from a dietary perspective. So once I get a sense of where the family lies in terms of preference from a dietary standpoint, then we can go go from there and actually start talking about what can we do sort of in a very systematic way, and what can be eliminated, what cannot be eliminated, what be tolerated, what not be tolerated. What do you sort of think about these type of things? I don't necessarily like trying to do everything, right? Like you try to pick one and do it for a couple of weeks, see if it's helpful. Just do that one. Kind of similar to when you're first starting to feed your kid, right? When they're infants, right? You first start with, you introduce like pears, right? And then you do that for a couple of days. And then you introduce like the apples and things like that. But you take away one, just to start with, okay, I think it seems like dairy really bothers you. Okay, let's remove dairy for 2 weeks and see how you feel. If there's no difference, then you can go back to having dairy. Or let's go over caffeine. I feel like caffeine is a really big thing for you. Like you're always drinking, you're always going to Starbucks before you go to school and things like that. Everything. I feel like that's a big part. Or, sometimes it's like artificial sugars. Your body doesn't digest artificial sugars well. So sometimes that leads to some of the bloating symptoms that patients have. And so we talk about that, or the sugars that they're just sort of eating. Let's reduce some of the sugars. I've been talking about that, for a long time in the family, and then we kind of, we collaborate on terms on, and also with the patient, not just the parent, but the patient also, what is actually feasible, right? I can talk about all kinds of things. Let's take away processed food, take away this, take away that. If the kid is in high school and going to school and is able to get and eat whatever they want to eat and drive wherever they're going to eat whatever they want to eat. Right. And so the parent doesn't have much control. They can say they have control, but they don't have much control of what the kid is actually going to put into their body. And so, trying to come up with a solution of something like, let's identify some foods or a food that we might think may be problematic for you, or identify certain type of things you're willing to sort of do that might be helpful for you. And then let's focus on that for a short period of time, and see if it helps. If that doesn't help, you can try something else. And we try to do it. I try to do it that way.
Now, you were saying that, a lot of folks may have, lactose sensitivities or gluten sensitivities. And, I know there are fructans, galactans, all these other things out there. Do you ever use, say, maybe working with a dietitian to say, we're going to try doing a FODMAP elimination diet and then slowly re-adding? I know FODMAP in general is just a very difficult diet to
right.
Also exclude all these great amount of foods, but also know some people are at their wits' end in terms of their pain. They were just willing to do anything. Is a FODMAP elimination with reintroduction with the dietitian helping guide that? Is that a sensible way for some of these patients?
It certainly can be. I look at a FODMAP diet as being a very specific type of treatment, right? It's not necessarily. I don't think of it as a okay. Let's identify let's pick a food that you think might be problematic, and let's try to either reduce that food or get rid of that food. Let's say dairy or gluten. FODMAP, I feel like in itself is its own sort of low FODMAP is its own kind of treatment. So I'll work with get a sense of can you even do this, right? It may be so restrictive that they're like, this is not going to work at all. My experience has been that younger kids that parents have a little more control over what is going into their body can do a better job of just adherence to that particular diet versus older kids or teenagers where the parents don't have as much control of what's going into their body in terms of compliance, in terms of being able to do that diet successfully. In terms of it helping or not, I have not experienced much of a difference between the two, based on age. And then, but I do have them work with a dietitian, do it under the guidance of a dietitian to work with if they want to try to offer it as an option for them. But I will say the overwhelming majority of patients either have tried it at some other point in time or read about it or things like that, or just opt not to do it and want to just go ahead and try to do something else in terms of reducing something else that they may feel is kind of problematic for them. I would say the most common are probably eliminating dairy and or gluten. Are the two most common, in my clinical practice, and the third one is kind of is removing or reducing the amount of sugar intake that they're taking in.
Now, one issue I often have with many of my patients who have lots of different diseases that may need special diets is, especially when we come to certain populations with food insecurities, is this something, and we also have a lot of kids who they get their food straight from school lunches and stuff like that, where there's always, a carton of milk and, it's probably some bread products. If you're starting to deal with this stuff, is this something that you have to work on writing letters, reaching out to school systems to trying to figure out how we can get this settled for our patient?
Yeah. So we write many letters for dietary, sometimes for dietary interventions, also for bathroom, things like that. Water intake is huge. Water intake is another big sort of piece for many of our patients. Making sure they have good, adequate water intake, so they have enough water bottle, things like that, and everything. I will say that I have not had to write for a specific type of diet. The schools have been actually pretty good about that. It has more to do with a lot, kind of more broadly allowing families to bring in certain types of foods, or if they have certain types of snacks, or eating at a certain time, things like that. So kind of more broad sort of food related letters and things like that to the school. It's pretty rare that I have to write letters to the school about eating certain types of food, if that makes sense.
Awesome. So I feel like we captured diet really well, and it sounds like where, as you would say, where you would start for us, if we're all the primary care doctors who are starting somewhere, it sounds like dairy, gluten, sugars is a good place to go. Before we move on to the CBT kind of in neuromodulation question, I think Sydney had one more question on probiotics. Is that right?
Yeah, just one really quick follow-up there. You mentioned that there's not a whole lot of evidence, or rather that there's mixed evidence on this. I'm curious if families express interest in the probiotic direction, if there are particular strains that have better evidence for this, or kind of how you would approach that.
The probiotics that seem to be helpful for some patients are ones that have lactobacillus in it, or ones that have BSL number 3. And I kind of leave it at that. When it comes to probiotics specifically for belly pain, The challenge when it comes to like the microbiome and things like that, because we talked a lot about how the gut-brain interaction sort of works, the brain and the enteric nervous system. But in reality, it's probably more of a triad. Quite honestly, it's probably the brain, the enteric nervous system, the microbiome, right? And that's probably and there's sort of bidirectional communication that's happening there. And so a lot of patients actually will come in with like these profiles of like their stool. And they've seen someone or done some kind of like stool analysis of things like that and everything, of their microbiome and things of that nature. And where we haven't gotten to a place in medicine from a chronic belly pain standpoint, how do you go therapeutically modulate that microbiome so that it actually helps with symptoms, right? We don't really have that answer, right? And so so sometimes they'll come into the office with, here's what my microbiome says, right? They went to some place or got this information, which probiotic should I take? I'm taking all these different supplements to fix my microbiome, and we just don't really have the data to support, the scientific evidence to support, like do these type of probiotics in this order, with this dose, at this duration, with this frequency, and you will change your microbiome to look more like this so you don't have belly pain, right? And so we're not there yet from a microbiome standpoint. Maybe one day.
And so, here we are trying to get to the last piece of the puzzle. I feel like as a primary care doctor or as a generalist, I can start some medications, whether they will help or not. I can definitely recommend some dietary changes, and we can work as a group to decide those pieces. And then, whether we insert probiotics or microbiome analysis and things like that. Well, not the analysis component, but I mean adjusting the microbiome, we can probably get doing. But the one thing we probably can't do, honestly, is, unless people are trained in cognitive behavioral therapy, but they might not even have the time in their clinic, even if they are trained in it, is to do kind of cognitive behavioral therapy for the gut and even those neuromodulation things. So these probably, just getting to that last third bucket, I imagine these are all, for us as generalists, probably referrals to these gastroenterology multidisciplinary clinics, where you guys would end up either connecting to a GI psychologist and being able to provide some of these neuromodulation things. Do these things exist anywhere else, or is it mostly through you guys?
So many primary care offices have psychologists or have access to some psychology to some degree. And so you can certainly refer patients, especially if you think that there's a component of mood related disorders to maybe their symptoms, or like in our case, schools seem to be rather problematic. And so there are things that maybe sort of we work through with psychology that you can necessarily have them come to a multidisciplinary GI clinic per se. Right. But there is a bit of a difference in terms of general psychologist, and like a GI psychologist. Right. Because the general psychologist will sort of work on particularly the anxiety, the depression specifically, but may not necessarily connect that with the physical symptoms the patient is having. right? And so the GI psychologist does an amazing job of helping the patient sort of see and develop skills, how they can use their skills that we typically use for anxiety, depression, things like that, but also use those skills to help reduce your symptoms, right? Also come with strategies to also improve your function. Okay, you're not sleeping. Let's come up with some sleep. Let's come up with some better sleep strategies. Okay, you're not eating. You're not eating as much. Let's come up with different ways you can sort of do it. You're not going to school. Let's come up with strategies to help you return back to school, right? And then when you get to school, let's come up with strategies to help your symptoms and reduce your symptoms so that you can stay in school, right? Because it's one thing to get to school, right? But then you got to get to school at a timely fashion, right? And then you also have to stay there and not get called home and have your parents come pick you up, right? Because that could be even more disruptive in some cases, right? Where patients, the parents actually at work and have to leave work and come back, as opposed to patients just staying home in some cases. And so I think there's maybe a place there if primary care does have access to mental health services, but I still think that there's a role for GI psychology in the sort of treatment of the chronic belly pain and how they're connected to one another. For the things like neuromodulation, that is something that can be done that's something a gastroenterologist does. Other non-pharmacological things that have been shown to be helpful for some patients, the use of acupuncture. There are many folks in the community that do it. Some are traditionally allopathic or osteopathic trained folks, physicians that do it, or there's some folks that are not necessarily physicians that do it, that are in the community that do acupuncture for chronic pain. That can be helpful. Physical therapy also, once again, you can refer to physical therapy. The way that I have families ask about it is that I have them identify a physical therapy clinic and just have them call and ask, is there someone in your clinic that does, and in your physical therapists that do abdominal pain PT? And if there's someone that does it, then you can send the referral to there. Because sometimes the physical therapy place may not necessarily say, the practice may not say, oh, we do abdominal pain PT, but there may be someone there out of the physical therapists that are in their organization that has a particular interest and does this type of physical therapy. I find in particular my patients that are student athletes, they particularly like physical therapy. But I'll use it for anyone, especially folks that maybe want to try other things, other medications, or they try medications have failed, and they want to do other types of things outside of stuff we tried or we had talked about, or they have a preference for that.
Can you go back and talk a little bit more about neuromodulation devices? Because I feel like every time I look it up, there are 10,000 different devices. I've definitely seen things for migraines and all the other things, and some are prescribed, some are over the counter. Can you explain what are neuromodulation devices, how they work, and what types of devices we would see for chronic abdominal pain?
So, for example, like our center is the name of the company is called NeuroAccess, and they have a device called IBSTEM. It's probably the leader in neuromodulation in terms of they provide percutaneous nerve field stimulation. It's called IBSTEM. We are a center of excellence for IBSTEM. I guess Cincinnati Children's. There are many places around the country, or not many places. There are places around the country that are using IBSTEM, that particular device and that particular company for neuromodulation for chronic abdominal pain. They have a FDA approved device for kids. It's for the treatment of chronic abdominal pain. FDA approved for kids between 11 and 18 for chronic abdominal pain.
Are there other similar devices from other manufacturers as well?
So not that I'm aware of that are FDA approved for children. So the device that's FDA approved for children is through this particular company. The name of the device is called IBSTEM. It's a device that you use. The patients wear it for a total of 4 weeks. They have it for 5 days on, 2 days off. It sits behind your ear. You have leads that go on the ear. And you stimulate the nerve fields. You're not stimulating the nerves directly. You're stimulating a field the nerves are running through. And you're desensitizing that gut-brain pathway. The patients wear it for the 5 days, and then they get a 2-day break. After that, they come back in and we do it again. And we do it for a total of 4 weeks. And the data that has been produced at a national level, multidisciplinary, there's been multi-center trials. There have been a number of trials that we've sort of done at our institution. There's also been many trials done at other institutions, and various different sort of data that's out there really showing the efficacy both in sort of improvement of function and reduction of symptoms for patients, and it's becoming, the use of that particular device is starting to become one of the standards of care for the treatment of chronic abdominal pain for kids.
Cool. This seems like a pretty cool type of thing that's definitely leading edge and something that we would probably be obviously asking our GI psych colleagues for help on this situation. Another thing I was wondering about is this other approach that probably I assume only psych or GI psych would be around is something like, transcranial magnetic stimulation, like TMS. I know that it's been recently approved for like at least adolescents, and I've seen lots of great use in some of our adults with a bunch of different psychiatric disorders. Have you seen any research or any thought on using that in pediatrics for this type of disease process?
I have not seen that in particular. It doesn't mean it's not. I just have not seen it used in particular right now in terms of being the a common or sort of a new emerging standard of care for functional abdominal pain specifically.
Thank you so much for this excellent overview of the many different management components in this. I feel like that was just a really great way of framing it and helping us kind of delve in on specific pieces. Kind of moving on from that to talking about the general field, the general concept and issue of functional abdominal pain. I'm curious, are there any significant disparities between racial groups, geographies, sexes, et cetera, when it comes to getting diagnosed and getting effective treatment for this?
Yeah, so it's a great question. And so a few things that we sort of notice in the pediatric population is that the majority of patients that come into service and come into care tend to be female. Tend to be Caucasian, and normally they're sort of teenagers, school age kids, but mostly teenagers. That is kind of the stereotypical patient that normally presents with chronic belly pain. That is not necessarily in line with the adult data that's out there. The adult data, it's a little bit more heterogeneous in terms of people that present with belly pain. With that being said, we also know that patients that are Spanish speaking, we also know that patients that are Black and African American tend to present with chronic belly pain to the ER with more frequency than they present to than Caucasian patients in terms of when it comes to chronic belly pain. And what we realize is that pain is not homogeneous, right? And so they're likely groups of folks that are not necessarily getting to their doctors and getting their belly pain addressed. Their primary care doctors, they're presenting other places. They're not getting referrals to gastroenterology to get some of the treatments. And so there are groups out there that are looking into making sure that the care that everybody gets care, the care they sort of need, so they can live productive and healthy lives in that way.
I really appreciate your take on the matter and being able to talk so well on the subject. So as we start to wrap up, I think one of the last questions we really wanted to ask was, considering we're taking care of so many of these patients, sort of in our pediatric and adolescent populations here, what type of prognosis are we looking at? Like, we have so many different types of treatment modalities, between us and as primary care, between our specialists. What is the outlook for a lot of these patients? Do we tend to be able to find good treatments for them? Is this something that they will have to live with the rest of their lives? Do they outgrow this type of thing?
So the way I think about functional abdominal pain is I think about it from the idea of, I try to look at it through the lens of as a chronic illness, but not in the sense of more in the sense from a chronic illness in terms of, did you know that you have a sort of predisposition or you have a certain sense of hypersensitivity when you have with certain types of triggers. And so the goal for you is to let's learn how to function despite the symptoms that you have. And let's get the symptoms reduced enough while you can still sort of function. And then, but understanding that, okay, when I'm having belly pain, it's not something catastrophic that's happening. This might be my functional abdominal pain. This might be my irritable bowel syndrome, right? And I can still go to work. I can still go to school. I can still do the things that I want to do and do the things that I need to do. And that's just as helpful for the patient as it is for the parent, right? So the parent is not necessarily adding to the catastrophizing nature of when the kid has belly pain and feeling like what's wrong, always asking them about it necessarily, or pulling them out of school, or always picking them up and giving them tools to be able to sort of work through their symptoms. And when patients buy into that sort of gut-brain interaction and really working on sort of function first, they do tremendously well. And they're able to do all the things they need to do, all the things they want to do, but they also learn their body a little bit more. That becomes incredibly great skills for them to learn as teenagers or as young people that may be helpful later on. So when they get to college later on, they know they have a big test, and all of a sudden they have diarrhea before the big test. Oh, this is just my, disorder. Or this is just my brain and gut acting funny. Let me calm down. Let me get to studying. Let me take a deep breath. Let me use my skills and tools so I can go about and take care of the thing I need to sort of take care of. Or when they become up parents one day and their kid is, driving them up the wall and doing things that are, they're getting paid back for all the things they did to their parents, and their symptoms are their belly pain might be ruined, or they know that their abdomen may be a little bit more sensitive. They're still able to, be able to go to work and take care of their family and different things like that. And so many of the patients that we see, the parents actually talk quite a bit about how they have GI symptoms as well. And IBS or functional abdominal pain or these type of disorders of gut-brain interaction, and the overwhelming majority of the parents, their symptoms started when they were kids. And so our clinic visits are many times just as informative for the patients themselves as it is for the parents, because they're still dealing with some of these things. And they'll say, I never had anyone explain it to me in this kind of way. I wish I knew this back when I was 15, right? And so, or some of the things they're writing down notes and things like that. It's like, no, we're typing all this stuff. We'll go get this information. They're writing it down for themselves just as much as they're writing it down, for their kid. And so that's always super rewarding from that standpoint, because you can really help families. Yeah. And really help families, not only if you help their quality of life improve and their function improve and reduce their symptoms, but sometimes you can actually really truly actively indirectly help the parents as well in their symptoms.
Yeah, it sounds like that you could deal with these symptoms for your whole life, but if you've developed the skills as a young person with which to treat these, it sounds like these skills are useful for your entire life for a lot of different things, and so you could definitely succeed. So that's why we try to treat it now. That's why we're learning all about it. That's why if you learn your 3 buckets, learn these pieces, see what we can do to attack this now, because you can set people up really well for the rest of their life.
Although I would also like to point out, one of the things that you said, I also feel is really important is being able to diagnose the patient with this disorder, this functional abdominal pain, being able to give it a label, give it a name, so that it's just something that they know they can call. For so many of our patients with other types of diseases, whether it's long COVID or ME/CFS or all these other different diagnoses, the fact that we can diagnose it and say, this is what you have, I think also empowers the patient instead of them just being like, I don't know what's going on, and everyone feels out of control for both the patient, both the parents. I think that's also an important thing that I think to point out that you said. Absolutely.
And one thing I also wanted to add in, I guess maybe add in back earlier on when we talked about diagnostics, I just want to add this one little piece. I thought about it earlier and I just forgot to mention it because we were talking about other things. When it comes to diagnosis of functional abdominal pain and the nervous system of the GI tract, I mentioned before the nervous system, GI tract controls how things move and also how things feel. And so there's a motor part, a sensory part. We can do tests for the motor stuff. We can do tests for how things are moving, how fast, how slow, things like that, if they're contracted, if they're dilated. We cannot do tests for the sensory things, right? The sensory component of the nervous system. And so when we're talking about pain is a sensory component that's related to the nervous system of the gut. So we don't necessarily do testing we don't do testing for functional abdominal pain, because that's a sensory component of the nervous system and how the nervous system, the brain, and the GI tract are talking to each other. And so we have to use the history, and you have to use the history to really make the diagnosis, because there are no tests for the sensory component of the enteric nervous system. And I lay that out. I tell that to families and stuff. And so they may ask, why can we do testing for functional abdominal pain and things like that? We can look for other things that cause pain, but we're not doing there's no test for functional abdominal pain per se.
Coach, this has been a really fantastic, really comprehensive overview, and we cannot thank you enough. I want to kind of move towards wrapping up with just asking, do you have any main take-home points that you would like to share with our listeners?
Yeah, so the main take-home point is that many times chronic abdominal pain for children can feel overwhelming. Many times you can feel helpless. You can feel like you don't have any answers or know where to go, and it's totally all consuming your kid's life and your family's life. And I would say, one, that there are options, there are things available. We can treat this, and also when we think about treatment, the goals of treatment are function first. We always think about want to improve function, and while we're improving function, we also want to reduce symptoms.
Awesome. And then our last piece to the puzzle, anything you'd like to plug, any societies we should check out, anything that you want us to check out, your own web pages, please tell us. We'd love to share with our listeners.
National Again is a great organization. A lot of great work is happening out of there. There's and also I guess AAP also has some great work as well for pediatricians and access to some of the great material.
Perfect. Thank you so much for joining us. Thank you so much for educating us, and we are really ready to attack some of this ourselves, but we'll still call for help. Don't you worry.
Yeah. I appreciate it. Thank you very much for having me on. It's an absolute pleasure.
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our bi-weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Sydney Engel, and our wonderful social media team, which is mostly Denise Cruz on X, Blue Sky, and Instagram. I've been Sam Mazer.
I've been Sydney Engel.
And this has been Chris the Chew Man Chew. Thank you and good night. And if you made it to the end, of course, you're going to get another poem written by AI. This one's titled Gut Feelings. My tummy hurts, a small voice cries. Around the navel, pain that flies. No fever, blood, or weight that's lost, but school days missed at morning's cost. The gut-brain axis speaks its truth through signals sent from childhood's youth, when stress and worry find their way to bellies that ache day by day. No labs or scans will show the cause. This functional pain needs different laws. With listening ears and gentle care, we help these children learn to bear. Through CBT and dietary tries, probiotic and peppermint prize, the pain is real, though tests are clear. These gut feelings we hold dear. See you guys.